intro training for our new CBOs in ICAN for Action for Older Persons, Nassau-Suffolk Law Services Committee, and Southern Adirondack Independent Living. And we are so pleased to have you all joining our network, the day after tomorrow. We might have a few other people in the ICAN network joining the call either today or tomorrow because our other regions have been coming online very quickly as well, and we'll have some relatively new staff who maybe hadn't made it to some of the other trainings that were held earlier in the winter. So the goal here is really for today to train not so much about the substantive programs, but about just ICAN itself, and kind of to the extent that we have ways of doing things already sorted out, making sure that everybody's aware of them, and giving you guys a chance to ask questions about how things work and stuff like that. The scope is going to be really for those of you who are dealing with the day-to-day work of ICAN and some of the administrative stuff, but not so much the financial end of things. There actually was a separate training that CSS's finance department did on the invoicing process for getting paid under this subcontract, which is its own very lengthy training. So I will circulate the recording of that to you guys, and you can make sure that the right person in your programs has a chance to look at that. For those of you who are CHA grantees, it may not be too different. It may be pretty similar to what you've already experienced, but I think it's different enough that it's worth taking another look at it. So why don't we just start with a round of introductions? Everybody should be, all the lines should be open. And if you, at some point, if there is, other background noise going on in your office, if you can just mute your line, you'll be able to mute yourself through the GoToWebinar app. And I can always unmute you if you have to ask a question later. So I'll start with myself. I am David Silva, the program director of ICAN, which is, we use that word a lot. We should probably say what it stands for, the Independent Consumer Advocacy Network. And I started here at CSS in November, a full 2 weeks before ICAN went live. So lack of preparation is something it's a way of life for me. And I'm very excited to have a chance to work on this program. I had, prior to this, been with New York Legal Assistance Group, and before that, Self-Help Community Services, in both places working under the amazing mentorship of Valerie Bogart, who a lot of you probably know about. And this was just a once-in-a-lifetime opportunity to really take some of the experiences we obtained through helping people with MLTC in New York City, and getting a chance to really make a much bigger impact for people across the state as that program continues rolling out. So AOP, why don't you guys introduce yourselves?
Hi, my name is Cassandra Hamilton. I'm the executive director here at AOP. I've been with the organization for a few years now. I actually started as the HICAP coordinator, so the Medicare counseling program, and moved into the executive director position just over a year ago now.
And I'm
Congratulations.
Thank you.
I'm Courtney Cashman, and I am currently the HICAP program coordinator, but I'm going to be transitioning over to the program coordinator for this new program. I've only been with AOP since last June, so a bit of changes already, but that's pretty much it.
Well, that was plenty of time to become an expert on everything Medicare related.
Yes.
So it should be no problem for you to become an expert on managed long-term care in 2 days.
Yeah.
We're big supporters of short timelines here, so it's okay.
Great. Thanks, guys. So then let's go to, in alphabetical order, Nassau, Suffolk.
I'm Vicki Osk. I'm the managing attorney here, and this is very, very new to me, although I do supervise other health-oriented units.
And which office, are you all in the same office of Nassau, Suffolk, or are you in different locations?
Well, I cover Nassau and Suffolk, so I'm not in one particular office. Denise and Ashley, who are the staff attorneys, Denise is in, and Melissa is in Nassau. Denise is in Suffolk, and Ashley's probably going to be bi-county.
So Denise and Melissa are in the Hempstead office?
So Denise is in the Suffolk office. Melissa is in the Hempstead office. They're both split on different grants. They're going to be doing this, and Ashley, who I think is going to be doing this full time, is bi-county, and she'll be uniting the different offices.
Okay, great. So who else do we have on from Nassau, Suffolk?
Oh, so hi, David. This is Denise Snow. I am the my project has been the cancer project all along. So so this is mostly new stuff for me, but not entirely. So I'm really excited about it.
Hi, I'm Melissa. I'm in the Hempstead office, and I'm also in the cancer unit.
Okay.
I'm Beth Wicki, and I'm one of the administrators.
My name is Ashley Omobodede.
And could you hear that?
Yep, I can hear you.
Okay. So, Ashley, do you want to tell
I'm new here, and I'm currently working on the Managed Long-Term Healthcare project.
That's this.
Yes.
She's coming from the Mental Health Law Project.
Okay, great.
Betsy, do you want to explain who you are?
First of all, I'm only hearing about half of what's said. For some reason, the audio is fading in and out for me. But I'm the Director of Program and Contracts Administration, so I'll be in charge of the reports and that kind of thing.
Okay, great. So I think maybe, hopefully some of today will be relevant for you, but the real nitty-gritty stuff in terms of the contract finalization process and the budgets and the invoicing, we're not going to be going over that today or tomorrow. So we should just maybe touch base with our finance department and our contracts manager separately, and we can, give the people who need to know an orientation on that.
Okay, thanks.
But I think part of today will be, you obviously, if you feel like it's not relevant to you, you can feel free to sign off.
Okay, thanks.
All right, and is that it from Nassau, Suffolk?
Yes.
All right, and who do we have from SAIL?
Hi, Shirley Dumont, Director of Advocacy Services. I've been with SAIL for about 15 years. Our lead on this will be Hannah.
Yeah, and I'm Hannah Carroll, and I've been working on the Community Health Advocate Grant since July, so I'm going to be transitioning over to this.
Okay, great.
My name is Jocelyn. I'm the Director of Navigator Services at SAIL. Been here for about 5 years and just sitting in and being part.
Okay, great.
And I'm Rachel Flieger. I have been working with Hannah somewhat on the Community Health Advocates Grants, and we're just interested in learning more about the ICAN and what we can do to expand our services.
Dynamite. I'm glad to have some veterans of CHA, because as you'll find out, a lot of ICAN is kind of built off of the CHA template. We're using the same hub and spokes model, some of the same subcontractors. We're using the same database, the same phone system. So that definitely made it a little bit easier to get things off the ground quickly. That we just clone community health advocates. But there are going to be some, some significant differences, which you guys will find out soon. Anyone else from SAO? All right, and then anybody else besides those three organizations on? Scott, I saw that you signed in, but I can't unmute you to hear you talk. So I'll just introduce you unless you want to get your audio working. It's Scott Weiser from Westchester Disabled on the Move. They're our community-based organization that's been covering Westchester and Putnam counties since January 1st. But Scott just came on recently to help them with that work, so it's a good chance for him to get brought up to speed on all this. Did I miss anyone? All right, great. So we can forge ahead then. And some of this maybe we already talked about, but just kind of starting out with what is ICAN, how is it organized? And if you have any questions, just jump in. You're all unmuted, so we can address questions as they come up. So as you all know, especially those of you who've been working on community health advocates, a lot of the Affordable Care Act has really focused on the uninsured, expanding affordable, fair health coverage to people who are uninsured or people who can't afford health insurance. And so you've had the Medicaid expansion, you've had the exchange, and so all of the navigator work that you guys are doing at SAIL, and the post-eligibility work through CHA is all really related to that. But there, as probably you all know, the ACA has a lot of juicy programs hidden away in it that don't get a lot of press, among them focusing on the high cost and relatively low quality of care for duals, so people with Medicare and Medicaid, and also a lot of significant reforms to the Medicaid long-term care benefits. A lot of that actually affects other states more because New York already had a very robust home and community-based services benefit under Medicaid, but we've seen we've seen some changes on a federal and more changes on a state level with that. Dual eligibles are really have a big target on their heads from a budgetary perspective. They have kind of the opposite problem of the uninsured. They have two different government-run programs providing sometimes overlapping coverage for them, and they constitute a disproportionate share of the cost for both programs. Now, there are obviously very good reasons for that, because if you happen to be both low income and an older person or a person with disabilities, you're just likely to have more costly care. You're likely to have more chronic conditions than other Medicare beneficiaries or other Medicaid beneficiaries. But the government feels like there's room to squeeze more savings out of this population. This is kind of some low-hanging fruit. And there is some basis for that. For example, the fact they duals actually don't receive good quality care in general. And I think a lot of people believe it's because there's not good coordination, that they have two different fee-for-service health insurance programs. And so providers in those two different programs are kind of billing those programs for whatever services they can get paid for on behalf of their patients who are duals, but nobody's really making decisions about what's the most appropriate level of care for someone, or let's think about ways to better manage people's chronic conditions instead of just paying every time they have an acute episode. Now the problem, of course, with addressing that problem, trying to tackle that, is that they're two completely different programs operated by two different levels of government, Medicare being federal and the state, and Medicaid being state. And so one of the ideas that came out of the Medicare-Medicaid Coordination Office, which is a creature of the ACA, was a financial alignment initiative, or a duals demonstration, as it's been called. So this is a way to combine Medicare and Medicaid into one plan run by either a private HMO, like a Medicare Advantage plan, or there are some states that have done a managed fee-for-service model, New York not being one of them. So New York has a duals demo, and it's called FIDA, and it only affects the certain downstate regions. So it's only New York City, Long Island, and Westchester counties. So for everybody except Nassau-Suffolk, you can tune out whenever we talk about FIDA, at least for the next few years. I'm sure after 2017, the state's going to want to make it, expand it statewide, but a lot of things have to happen before we can even talk about that. But in addition to FIDA, there's just managed long-term care, which is, obviously spread through most of the state already. And this is really a creature of state health reform efforts through the governor's Medicaid redesign initiative. And as probably you all know, in 2011, one of the hundreds of Medicaid redesign proposals that was adopted by the legislature was MRT 90, which is the initiative to make managed long-term care mandatory for most people who need home care or other long-term care services. So this is the bulk of what ICAN will be doing, is helping people who need to enroll in an MLTC plan or who are already enrolled in an MLTC plan. This is the new dominant mode of providing those different long-term care benefits that previously were delivered through a whole host of different mechanisms under the Medicaid program. I mean, you had just the personal care benefit, which was a prior approval service through the local Department of Social Services. You had certified home health agencies that would sometimes provide long-term care. You'd have the different waiver programs like the Lombardi, the TBI waiver, the NHTD waiver, and then you'd have different sort of facility-based care like adult day health care or nursing home care. And you have consumer-directed personal assistance program. And I think a lot of people in the state felt like it was pretty arbitrary which of these people ended up in, and that if you sort of looked at them across programs, you would see that there were a lot of people in nursing homes who looked like they could be served in the community, and there were some people who were getting CHA services, but it wasn't clear why they weren't getting personal care, and the general underutilization of consumer-directed. So MLTC is the state's chosen vehicle for trying to unify and rationalize this system a little bit. And obviously they have, cost-cutting agenda as well. I mean, you guys all know this. Medicaid is the only insurance that covers long-term care services, so this is why a lot of people with ADL needs go the Medicaid route. And I'm sure that we've all seen, I mean, I definitely, I'm glad that I came into this line of work before MLTC was mandatory, because I feel like I got to see the before and after. So I remember having lots of appeals and lots of problems with the old fee-for-service personal care system and with CHA services, before MLTC was mandatory. So, to me, it's not so much, oh, the old system was great and the new system is terrible. It's more like, well, the old system was pretty lousy too, and the question is this the right, is this the right change, or is this the solution that will best benefit the Medicaid beneficiaries themselves? And those are kind of questions beyond the scope of ICAN. But I think we can all agree that since this is the law of the land now, it behooves us to try to help people navigate it the best that we can. And to the extent that there are possible benefits of MLTC, making sure that people actually get those benefits. So MLTC is only mandatory for duals. For people who only have Medicaid, they have long been required to enroll in mainstream managed care plans, which have been required to provide long-term care services for a few years now. So within the scope of ICAN, you're going to have the majority of the clients who are MLTC, and then a smaller number who are Medicaid onlys, who are in mainstream plans, but have very similar needs to the MLTC population. If you're in a mainstream plan and you need personal care services, the kind of issues you'll have will be similar to someone in an MLTC who needs personal care services. As I've probably given in my spiels to all of you, I really feel that there has always been an ombudsman program for these folks in New York State, and it's been this tremendous network of legal services and social services organizations who have been stepping up to the plate and helping people with these programs without any state funding, in many cases, without any coordination, just because there was a need and you guys went out and found the funding to pay for the resources to help those folks. And so to me, ICAN is just a chance to finally give an official blessing to that existing network and provide some more resources for you to do even more of that. I know in CHA, the Community Health Advocates has been getting cases, MLTC cases, and helping people with that. I know you guys at Nassau Suffolk have been doing a lot of work for those clients. So this is really the kind of making it official of an existing ombudsman program. So part of the state's, the conditions that the state placed on, the conditions that the federal government placed on the state doing FIDA and doing mandatory MLTC, one of the conditions was you have to create a statewide independent ombudsman program. So it's a requirement of the federal government. The state has to do it. And it also happens to be something the state really wants to do. I think even all the way up to the top of the Medicaid program, this is something that Jason Helgerson, the Medicaid director, felt really strongly about, creating a robust ombudsman. And interestingly, they actually turned down federal money to create this program. It's state-only dollars. The other states that have ombudsman programs for their duals demonstrations are a lot more limited. They're not as well funded. So this is like the, really like an example for the rest of the country in how to do consumer assistance when you're creating such wide-reaching reform efforts in your state Medicaid program. So what we're going to do is, obviously the duals demonstration was kind of the impetus for the creation of these ombudsman programs, but New York State goes beyond the duals demo to our existing MLTC program and, as I said before, to people in mainstream plans who need long-term care. So what we do is educate, we advocate, and we help people appeal. That's it in a nutshell. So we do a lot. We'll be doing a lot of community education, a lot of speaking engagements, presenting to groups large and small, of all different audiences: consumers, caregivers, providers, professionals, and just getting word out about the rules of the game, how these different programs work, making sure that people understand what they're eligible for, how to enroll, how to solve problems, if they want, how to request more of a service or make appeals, and then of course advocating when people run into problems and making sure they know that they can call us or they can call you guys and have someone either walk them through the process of fixing the problem or just fix the problem for them. And then, of course, some of those issues will require a formal appeal, and ICAN does have the authority, the mandate in our contract with the state to represent consumers in appeals. So we can do internal appeals against managed care organizations. We can do fair hearings against the state. We could even potentially litigate, but we just have to, before you file any court papers, just let me know, because we, as a standard contract, since we are a state contractor, we're not allowed to use ICAN money to sue the state. But if you have, for example, Nassau Suffolk, if you guys obviously have other funding sources that you can use to, bring claims against the state, as long as that's kind of segregated from your ICAN work, obviously the state can't stop you from doing that.
Okay, even though it's the same case, let's say we're now moving it on to our regular state funding. Let's say we lose the fair hearing, we're going to do a 78. We're now going to use our regular state funding to fund the 78. It's the same case, but that's okay, right?
I think so. That would be sort of an issue of first impression. So if you actually have a case like that, let me know, and we can maybe follow up offline. I mean, I don't see why not. I mean, that sounds right to me. I would want to find a way for you to be able to use ICAN money, quote unquote, to do the Article 78 if that's what needs to be done. But I think what they were really thinking about was like bringing class actions, bringing like impact litigation.
Affirmative litigation type of thing.
Yeah.
Okay.
Yeah. Whereas a 78, a 78 is just another step of the appeals ladder.
Oh, and
great.
Yeah, which is okay.
That would be great. Okay.
Yeah.
So let's.
All right.
Do you guys do a lot of Article 78s?
Yeah.
Yeah.
Interesting. Okay. Yeah. So yeah, let's talk offline about that, because that's a good question.
Okay, great.
One of my hopes, one of my great ambitions for ICAN, and I hope it works out like this, is that this gives everyone another tool in your arsenal of advocacy. And ICAN is all about sort of alternate dispute resolution. It's all about informal advocacy and negotiation, which is things that probably you all are using already. But I feel like it makes it a little bit more effective when you have kind of the imprimatur of the state. It's official. We're the ombudsman program. Plans have to deal with us. They can't just ignore us. And so far, the plan representatives have been highly motivated to fix things with us, rather than, kind of taking the attitude, well, we'll see you in court, and then all you can do is do a fair hearing. So hopefully that continues, and there won't be a need for a lot of fair hearings or Article 78s. But, there's obviously cases where plans aren't acting in good faith, or we have, legitimate disagreements just about the rules or policy, and we just have to, we don't want to have our hands tied behind our back in those cases.
Okay.
So CSS has the contract to be the Ombudsman program, and we are subcontracting out a ton of that work to you guys. And so we have three different kinds. There's two different kinds of subcontractors we have. There are the specialists and the CBOs, and the specialists are similar again to how the Community Health Advocates program works. So the specialists are organizations who we're really leaning on heavily to help us with program design, developing training materials, doing quality control across the network. They actually answer the toll-free hotline and develop consumer fact sheets and help us develop content for the website. So in addition to doing cases, they have a lot of other roles. They also provide kind of expert assistance for the CBOs on more complex cases. Now, some of the CBOs have no problem with complex cases. That's, your stock and trade. But for other folks in the CBOs, it may be that, maybe you're not comfortable doing a fair hearing or sort of a complex appeal type issue, and that might be something that one of the specialists can take off your hands or guide you through. Yeah, so those are the specialists, and the CBOs are, the main benefit of the CBOs is giving us that statewide reach. And part of our contract is that we have to have the ability to give in-person assistance to anyone in the state of New York. And we have to have in every county, there has to be the possibility to make an appointment with someone from ICAN to meet at a location in that county on relatively short notice with a client. So it's great you guys all were able to demonstrate that in your proposals, and that's why we've got you in the network. We don't take walk-ins, so don't have to worry about that. You're not required to do walk-ins, and we keep reminding the state of that every time it sounds like they're starting to make noise about that. So it hasn't been an issue. People can call and make an appointment, and then you'll follow up with them. So what's in a name? Well, confidentially, we didn't really pick the name ICAN. The state picked it, and it's, I don't think, the most descriptive title we could have come up with. I don't think there is a descriptive name you could come up with for this program that wouldn't also be incomprehensible to most consumers. So maybe this is the best we could hope for. At least it's an empowering acronym. But the I is the most important letter. We are independent. As you guys know, currently people's only source of information is the plans. And too often people are getting biased information or misinformation, and this is a chance for people to really have a conflict-free, truly conflict-free entity giving them information and advice and helping them navigate the system. The C was supposed to stand for community, but we got vetoed on that one, so it stands for consumer. I think most of us have a very strong background in the community integration movement and the principles of the Olmstead decision, and it really is a civil rights issue for us. But we also represent people in nursing homes, and there are a significant percentage of ICANN's potential clientele who are permanent nursing home residents, where obviously the first goal is always trying to help those people get back to the community if that's possible. But if even maintaining, if people want to stay in a nursing home, they are still potential clients of ICAN. They're also potential clients of the Long-Term Care Ombudsman program. And I know some of us are, AOP, you guys do the Long-Term Care Ombudsman program, right?
Yep.
Yeah, so you know, we're still working out kind of the boundaries between the two ombudsmen, the ombuds people. But you know, nursing home consumers are definitely within our ambit. Yeah, I mean, the word consumer is not a term that we love, but we're kind of stuck with it. So now it's in our name, and you know, so if you hear me using the word consumer a lot, I apologize. I don't actually think that it's a good way of talking about our clientele. The third word is advocacy, which of course is probably the second most important word after independent. And this is the network as it stands today. We're getting big. We almost covered the whole state. On this last round of RFP, we didn't get any satisfactory applicants for the Hudson Valley region, so we just released an RFP just for that Hudson Valley region, and hopefully we'll have a partner in the Hudson Valley going live May 1st. So we will be 100% statewide, hopefully on May 1st. But we've been operating on a statewide basis ever since December, just with the hotline. The fact is, we haven't gotten many calls from outside of New York City and Long Island, because the only way that people know about us is through the FIDA notices that the states send out. Those notices had our contact information on them. So in December, we were averaging about 100 calls a day at one point, because everybody in the New York City area was getting these notices about FIDA and panicking and calling us. So that was challenging, to say the least. We here at CSS had two health counselors plus myself answering the phones, and we were getting some help from Medicare Rights Center and some of the other specialists, but man, that was a tough month. So the call volume has died down a little bit, and what we're going to start seeing over the next, I think for the rest of this year, is that gradually more and more MLTC plans and mainstream Medicaid plans will be including ICAN contact information on their materials, whether it's their notice of action, when there's an adverse determination about somebody's care, or in their member handbooks and other correspondence. So that will start to drive a little bit more call volume from outside of New York City to ICAN. But the main thing that I think will drive call volume is outreach by all of us, which is going to be a big part of this, and it's been one of the hardest things to get going. But all of you have been doing your own outreach work for various programs, and the challenge now is to say, well, we're all going to do it in a coordinated way. We're going to use ICAN, ICAN branded and approved materials, and make sure that we're systematically reaching out to the populations who would benefit from this. So that's kind of a longer conversation that we can all have about what are the best ways of doing outreach on behalf of ICAN. But that's really kind of in its early stages right now. So this is what the network looks like as of today, and we're still, I've dubbed Region 8 is Action for Older Persons, Region 9 is SAIL, Nassau-Suffolk, you guys are getting Region 2, which was originally Nassau-Suffolk Hospital Council, and then was NILAG briefly. So we're glad to have a permanent organization covering that massive amount of population on the island. And then Region 10 will be Hudson Valley once we get that assigned. So you all know about the changes that have been happening over the last few years. and how that, how the need for an ombuds program is, I mean, long overdue. So we've talked about this a little bit. So the hotline, I mean, I think that the most important part of ICAN is this network, is you guys being able to have people who are experts on the plans in their area, the providers in their area, the different community-based organizations, knowing your clients, knowing the demographics, and just having that regional expertise is the most important thing. We don't want people to be calling ICAN and getting some call center that doesn't know anything about their circumstances. And so the second most important piece of it is, of course, the hotline. That's just an easy way for people to get someone on the phone who actually knows what they're talking about, who's going to be able to give them information right away. But, we're down, the hotline is down here in New York City. And so what we're going to be doing is when we get calls on the hotline, we are going to forward those calls directly. We're going to transfer those calls directly to the CBO in that person's county. So we're not even going to open a case. We're not even going to do an intake. Just the first question will be, what county are you calling from? And then we'll try to do a warm transfer straight to the appropriate organization so that they get that in-person, that local expertise. And then you would own the case at that point. And that's going to count towards your deliverables under the contract, and you'll take it from there. So with the hotline, none of you are going to have to deal with our phone system. Consider yourselves lucky. It's a very powerful but very finicky voice over IP phone system, and we have these BAT phones installed in specialist offices around the state. So we're, covering the hotline pretty well. We pick up. We have live answer within 1 minute when people call this hotline, and they're not getting like a screener or someone. They're getting a health counselor who can answer their questions, usually on that call. Someone who knows these programs, and we really strive to listen and give people a chance to tell their story before we start, interrogating them about their demographics and households and all that stuff. That, of course, those hotline calls are often just short advice calls, but they, some of them do ripen into cases, and so we're all, managing this casework component as well. And every case that comes through ICAN, whether it's the hotline or whether it's the cases that you guys get through your own, sources of intake, they all go into the database. So in a minute, we'll demonstrate the CHA database, which you guys at SAIL already know all about. That's going to be, that's the first major apology that I have to make to you all, is we don't have a way to track the casework that you're doing for ICAN other than making you re-enter all your cases in our database. It is a major drag, as I'm sure SAIL can testify. But I know you guys all have your own case management databases, which are probably perfectly fine and capture a lot of what we'd need anyway. But the problems of integrating this data across the state are enormous and not easily resolved. So for the time being, although it's on my wish list, someday I hope to have some massive data warehousing project. But for the time being, you just have to have someone on staff who at the end of every month goes into your database and then re-enters the cases that are eligible for ICAN into the CHA database. And we'll go over, how to do that. We have an email address that anybody can email to request assistance from ICAN. Right now, that's just being answered by my counselors here at CSS. We usually are going to follow up with a phone call. The outreach we talked about a little bit. There's the outreach to consumers, caregivers, other lay persons, and the outreach to professionals, providers. This is one thing where there just can never be too much outreach. Right now, downstate, this FIDA program is really suffering from the lack of outreach. And, the state says, look, we did lots of outreach. I don't know what you're talking about. But, apparently it's not enough. It's just so hard to reach every mom and pop doctor's office, pharmacist, nursing home. There's just so many people who need to understand this complicated information that we just need to get more people out there pounding the pavement and getting word out. ICAN has a website. It ain't much. This is our website right now. So it really just says who we are and how you can contact us. But we're very actively working with our web developer firm to create a much more full-featured website. It will have information in 8 different languages. It will have frequently asked questions. It will have a resource library where we can all be contributing content. We'll be able to put our fact sheets there. It'll have an interactive map of the state with all of your organizations findable on there. It will have, it's either through the site or through some other tool, we're going to have a password-protected portal for all of the ICAN agencies, similar to the CHA portal on the CHA website, where we can put kind of inside materials like different contact lists or templates, how-tos, policies and procedures, stuff like that. So we can share that just internally within the network. So then, finally, the other big piece of ICAN is reporting. And there are certain reports we're required to give to the state at certain defined intervals. We have to report on the calls to the hotline. We have to report on the cases that we've been working on. Those case stats are broken down by type of plan, name of plan, county, type of issue, all kinds of different language spoken, all kinds of different things that the state wants. And maybe more importantly, there are all kinds of ways that we could be using this data that it's not being used now. And this is one of the problems with having an uncoordinated effort of consumer assistance, is that there isn't anybody in a position to look at all that data that you guys are generating through your hard work and identifying trends or other issues and being able to look at that from a quantitative standpoint, and then be able to go to the state and say, look, we've had 200 cases in the last month where X happened. This is a real problem. This is not an outlier. So a way to really get past the policy by anecdote and into more data-driven policy recommendations. All right, so we talked about this already. All right, so the hotline, there's a couple different ways the hotline works. The most common is when someone calls the 1-800 number, it's most likely that someone from CSS will answer, and probably we're just going to take the case at that point if it requires resolution. Some of those cases we might warm transfer to a specialist if it's something that is beyond our our comprehension, like some certain Medicare issues we've been given to Medicare Rights Center. We've had other, other issues we've given to Legal Aid Society. The other potential route is there's someone calls the hotline at random. They may be, it may be someone from a specialist agency that answers the call. It might be someone from New York Legal Assistance Group or Center for Independence of the Disabled in New York, Empire Justice Center, and they may, again, they're probably just going to keep that case and resolve it. And then for you guys, for both specialists and CBOs, you're also getting cases through your own intake process. So one of the first things I'm going to ask everyone to do is just think about, we don't dictate a particular intake process. We're not going to make you change how you do intake. But just take a look at your intake process and figure out how are we going to identify the ICAN people and how are we going to make sure that they get to the person within the office who is sort of the ICAN point person, and try to shorten that path as much as possible. We want to have a somewhat consistent experience for people contacting ICAN, even though it is distributed across a dozen different organizations. And there'll be some information in the policies and procedures that we'll go over about how we do intake here at CSS, just as an example, not as saying, oh, we expect everybody to change how you do your intake, but just some things to think about. And for some of you CBOs, if you have cases that come in through your normal intake and it's over your heads or it's outside of your area of expertise, you always have the ability to warm transfer that person to a specialist. That's part of their job, is they have to take the complex cases that CBOs don't feel comfortable handling. And we're going to have every month, I'll make sure you guys are all invited, we have a monthly case review call where we all get on the phone together and we go through cases that we've seen in the last month, and it's a chance for everyone to really give feedback about what they've been seeing and to learn from each other as we struggle with these cases. All right, so are there any questions about this first part?
So David, this is Denise Snow, Nassau, Suffolk. What's the timeline for us needing a phone number to have the calls forwarded to?
I think I would say in the next week or two, if you can. I mean,
okay.
Ideally, just if you can give me a number that will work now, whether it's the direct line of someone who'll be working on it, or even if it's just your general intake number, and then at least that way I can give people something to use while you guys figure out a more permanent solution.
I have one other question. This is Bill Denise. You had said the program is to help anyone in the state, but are there income guidelines here? Are there specifics, or just anybody who calls?
That's a great question. There are no income guidelines.
No.
Yeah, because anyone who is an ICAN client is going to be a Medicaid applicant or a Medicaid recipient. And so the assumption is that if they're eligible for Medicaid, then we don't need to screen out by income or resources.
Okay.
Yeah. We really want to have a very broad definition of who is eligible for services from ICAN. We really don't want to be exclusive about it, and that includes not just consumers, but also caregivers, providers, even plans. I mean, if someone from a plan calls us, we'll talk to them. Someone from, an adult day center calls, at a certain point, we're going to say, well, you should probably talk to your general counsel, talk to your lawyer. We're not giving you advice on how to, how to run your business. But if they're calling about issues for their clients or for their patients, then we can definitely talk to them about it. Oh, okay, Rebecca, you have a question. Let's see. Oh yeah, is there a script that we should be saying on the voicemail for the transfer call line? I don't have a specific script for you. I think as long as it mentions ICAN, that's the main thing I'm concerned about, is just making sure that if we transfer a hotline caller to their local CBO and someone isn't there to pick up and it rolls to voicemail, I just want to make sure that the outgoing message on the voicemail makes it clear that they're still within the sphere of ICAN, that they haven't sort of been dumped on some other organization, you know, that it's still, you're still talking to someone from ICAN. You're going to get a, leave your name and number, and someone will call you back. If you want to hear what we put on our hotline, you can always, you know what, I can do, that's what, I can actually send that around. I can send around what the outgoing message is on the hotline, and that might provide some guidance. All right, were there any other questions about this first part?
It's Denise Snow again. Just briefly, you talked about outreach and the importance of outreach. Are we going to be able to talk about that in any little more detail at any point, or should I just speak to you separately on that?
No, we can talk about that in more detail, and probably now's as good a time as any.
So I guess my question is, where have previous organizations been successful? Where do you think you get the most bang for your buck on your outreach?
That's a good question. I think really we need to talk with the CHA agents. I think I need to talk to my colleagues in community health advocates and see what the CHA CBOs have done. I don't know if SAIL wants to chime in on this, but our approach has been pretty deferential to the CBOs so far, saying, well, you guys know who the major players are in your region. Yeah. You know where the clients go and who they trust. So those you sort of chart your own course. But I'd like to be able to give you some more support than that. I think for us downstate, with the specialists, we're trying to have a more coordinated approach because we're all kind of on top of each other geographically. Mm-hmm. We're all overlapping. So I don't think it makes sense for, both Legal Aid and Medicare Rights Center to be scheduling presentations with the same group. We need to kind of have a traffic cop. But for the rest of the state, it's been kind of, since you each have your own non-overlapping region, we've kind of been saying, well, you can, just do whatever you want to as long as you make your numbers. But I agree. Like, I think we need to give some more guidance on that. SAIL, do you have any tips for Denise? Wait, I think I probably.
This is Hannah from SAIL. I think maybe for this, just reach out to all long-term care, all of your nursing homes, all of your home health agencies. I think those would be places to start because they all deal with people who have long-term care already.
Yeah, that's what we thought. That's great.
I mean, what we've, in terms of my experience doing outreach at Self-Help and NILAG, Self-Help was great because we had senior centers and senior housing developments and naturally occurring retirement communities, these NORCs. I don't know if they have those on the island, but they have them all over New York City.
There is one in Nassau County.
Great. And those were a good way of getting directly to, being able to get a large number of seniors all in one place, and then, being able to give presentations and then arranging one-on-one sessions afterwards, for example, or doing follow-ups by phone. That worked out really well. And then you're also kind of cultivating a relationship with the social worker or community worker or whoever it was at that site, that when they had cases that they didn't know what to do with, then they call you because they know you from the presentation you gave. Another thing you might try is like local bar association, or if they're like a chapter of the I know actually NILAG already hit this one up, so sorry, they got scooped on this, but the National Association of Social Workers I'm assuming they have a Nassau chapter and they have a Suffolk chapter, and I think they're speaking, I think someone from NILAG is speaking there at their meeting in June, I want to say, and those, or even like private, honestly, like even private elder lawyers have like marketing events that they get pretty good turnout for. So those are all, things you can try. But I'll see if I can get you some more, maybe we can circulate kind of a tips for outreach for the CBOs.
So you brought up a really good point. There's or has anyone felt any competition or conflict with the private bar elder law attorneys who do these kinds of appeals and fair hearings for home care?
I haven't. I mean, they've been. I mean, maybe they're just not telling me. But I mean, so far, I have a lot of relationships with members of the private bar. I spoke at the annual meeting of the elder law section of the state bar, and I think people were just really eager for information. And I also have found that, while some of those folks do home care appeals, a lot of them feel like it's like outside of their wheelhouse a little bit, and they would just as soon refer those to someone else. So it hasn't been a competitive environment yet. It's really been one of cooperation.
This is Hoda again. Are we going to have other ICAN like pamphlets or stuff to hand out, or do we have to make all that stuff up, or is there something that's already been approved for
Great question.
That kind of stuff?
Yeah, we will have materials for you to use. We already have like a little one-pager on ICAN, and we'll have a lot more materials available for you soon. I mean, we're really hoping to just have like a library of resources that you can pull from. Everything that any written materials that we disseminate or publish have to be approved by the state. So that is a significant drag on efficiency, but I think that in the long run, it'll get easier. The reason why I don't have, the reason I don't have a lot of materials for you right now is in part because of that, because it's like finding someone who knows enough about it to write a fact sheet and then getting the thing approved by the state is time consuming. But we're about to finish a bunch of fact sheets we've been working on. The other thing is every fact sheet or handout that we have for consumers has to be written at a 6th grade reading level. That's like specified in our contract. And I don't know if you guys have ever tried this before, but it is impossible to write about MLTC at a 6th grade reading level. Like the very concept of MLTC requires like graduate school to wrap your head around. So it's been really hard to do that. But I think if you guys have outreach opportunities in the next few weeks, don't wait. Just sign up for them. Let me know, and we will try to make sure that you have what you need for those events. Okay? Because I'm sensitive that you don't want to pass up opportunities while you're waiting for a more perfect pamphlet. Do you guys have any other questions about outreach? I know there's a lot still unanswered, but.
No, it's helpful. Thanks.
All right. So we're going to switch gears now to the screening, intake, and database portion of our agenda. So this is from the Policies and Procedures manual that I emailed around. This monstrosity has a lot of stuff that's not relevant to you guys. I do not expect everyone to read this cover to cover. It's probably an excellent antidote for any sleep disorders you might have, but I don't recommend reading the whole thing. What it's really good for, hopefully, is just finding answers to specific questions about how is this supposed to work, or tips for different situations. So this chapter on the hotline is going to be irrelevant for all of our CBOs for the most part, because it's, you're not going to be answering hotline calls directly. But this section here with call protocol might be worth just checking out, just to give you a sense of this is how we're doing customer service among CSS and the specialists, right? So this is kind of our approach, and use with your discretion, right? Like, your results may vary, but what we've been striving to do here is flipping the typical intake process. I think for most places that do telephone intake or in-person intake, the first, from the client's perspective, what happens is they usually are talking with someone who doesn't know anything about the problem the client is having, but is just basically asking them name, rank, serial number, all these kind of nosy personal questions, so that they can fill out an intake sheet or check all the boxes in a database before you get to the point where that person actually gets to talk about the problem they're having, and talk about it with someone who will understand what they're talking about and be able to relate, at least relate to it on a substantive level. So we really, to the extent possible, try to flip that. We try to start with, just tell me why you're calling. Tell me your question or your issue or your problem. Put that up front, and just use good active listening, good client interviewing techniques to try to draw out the client's story, and start with that. And then we can go back and have this, after the caller spills their guts, then we can go back and set expectations for the engagement. Say, all right, this is who we are. A lot of people call us thinking that we're the government. We're thinking that we're the plan, and there's a lot of shooting the messenger that goes on around here. So an opportunity to just make it clear, like, we're nonprofit organizations. We're paid by the state, but we're independent of the plans, and we're confidential. So, and making clear that there are some exceptions to the confidentiality. I mean, we do report non-personally identifying information to the state, okay, when we do reports on demographics. And then just explaining, I'm going to be able to help you today. And then we move into, the more typical Q&A section, where some of the questions are just, dumb demographic things that we have to ask, and some of them are more, well, we need to find out more. We need to drill down and find out more about your situation, dates, times, who did you speak to, what kind of plan are you enrolled in, et cetera, et cetera. So, again, take it with a grain of salt. Some of you may already be doing this. Some of you may have very good reasons for doing it totally differently, and it's not my job to tell you how to change. This is a section on the scope of ICAN. This is important, although still somewhat fluid. The original RFA, we actually don't have the contract yet for ICAN. Once we have the contract, maybe this will crystallize a little more, but the original RFA from a year ago said that the Ombudsman will provide participants in both MLTC and FIDA programs and LTSS MMC plans with direct assistance in navigating their coverage and in understanding and exercising their rights and responsibilities. So the main factor in whether a case is within our scope is the client, whether the client is a participant in one of those three types of plans. And then we would also say if you're a prospective member of one of those plans, so somebody who maybe has just applied for Medicaid and now wants to enroll in an MLTC plan, that person would be within the scope. But there's a second factor, because we don't help MLTC members with their SNAP appeals, right? So the second factor is that the issue actually has to have something to do with your participation in a Medicaid managed care plan or your long-term care services. So on the next page, we have some examples of things that would be covered versus things that are not covered. And like I said, there's a little bit of fluidity here. So one example is, well, what if this is someone who hasn't been approved for Medicaid yet? What if it's someone who just needs to apply for community Medicaid? Is that within the scope of ICAN? And I don't have a great answer on that. I think the answer is generally no. But if you feel that in your region that that's going to be a big part of what you need to do, and that maybe you would have trouble making your numbers otherwise, let me know. I think a lot of it may depend on what are the other alternatives for people who need help with Medicaid application assistance. You know, there are other programs that can help with that. There will soon be a facilitated enroller program for people in the disabled, aged, blind category. So maybe we can make referrals to those organizations. Some of us may be those organizations. But generally, this is about what happens to you after you get Medicaid and you're either trying to get in a plan or you're having problems with your plan. Another example would be high cap work, right? So if you have a caller who is in an MLTC plan and they have a denial of coverage for a prescription drug under their Medicare Part D coverage, you know, that's really a high cap issue because it's not related to their MLTC enrollment. Now, ironically, if that same person were in a FIDA plan downstate, then a prescription drug denial would be within the scope of ICAN because anything FIDA would be within our scope. Are there any questions about these kind of scope issues? Okay.
David, it's Denise again. So I'm sure that this has happened to you, or maybe it hasn't, but I can't imagine. Do you get calls from people who want you to help them apply?
Yes. Yes. Not a lot. Not a lot, because like I said, most people find out about us because of the FIDA notices, and so those folks already have Medicaid. But we have every now and then gotten people who want assistance with applying, and we've been referring them to other resources, sometimes community health advocates. You know, I think it's just sort of a, it's almost like it's not ripe yet to be an ICAN case. Like they haven't started, they haven't even started thinking about managed care. They're just trying to get Medicaid in the first place. Someone who's not, I mean, someone who's not a Medicaid recipient is really not an ICAN client. If you just have Medicare and you know you have health insurance issues, that would be high cap. Oh wait, Amanda has a question. Okay, so Amanda at Empire Justice, who subsequently signed in. Hi, Amanda. Empire Justice Center is both a specialist and a CBO. They are covering the capital region. She asked a good question. What about an issue with long-term services and supports that is not managed care, but maybe is fee-for-service, like CHA? Would that be within the scope of ICAN? Good question. I'll have to ask the state on that one. A similar question we've asked the state is for waiver participants. So someone who's in the TBI waiver or the NHTD waiver, they kind of have a lot of the same types of issues as MLTC members, so maybe they're kind of lookalikes, and we'd say they're in the scope, but I want the state to give their blessing before we do that, in part because there's another program, there's the Protection and Advocacy grant that, is supposed to help people in those waivers, and so I don't want to be, accused of duplication or stepping on anyone's toes. But for someone who's just having issues with CHA under fee-for-service, again, I really want that to, I think that should be, I think the right answer is yes, that's within the scope, but it's not spelled out in any of our guidance from the state, so I'd want to get confirmation of that before we start taking those cases and then finding out that we shouldn't have been. But I will add that to my list of follow-up questions. All right, are there, okay, yeah, she said we already have a couple, so. Yeah, we haven't had too many long-term CHA cases just because it's so hard to get long-term CHA services anymore after they changed the reimbursement. So it's kind of a academic question. All right, so in the there's really kind of 3 different levels of cases that we talk about within ICAN. You've got your information-only cases, where we're really just giving advice. There's the navigation cases where there needs to be a contact with a third party, right? That we need to be calling the plan, or we need to be working with the Department of Social Services or the enrollment broker, and where you may be doing some negotiation, some informal advocacy. And then you have complex cases, which are really the disputes, where the person gets a notice of action from a plan that's unfavorable, a notice of disenrollment, services were discontinued or reduced without notice, where there's a grievance about the quality of care somebody's gotten. Those might be complex cases, or someone who's trying to get discharged from a nursing home. Okay, we can skip through that stuff. And I think when we're going to, Carrie and I will be following up with you guys to nail down work plans. And within the work plan, it will, we're going to ask everyone to try to guesstimate how many cases of those different types you'll be able to handle, for the contract period under ICAN. All right, so are there any questions about this, about sort of the scope or the screening process of figuring out whether something's an ICAN case? All right, so let's go to the database, and Sale, I apologize if this is very redundant for you, but you'll see some differences, and I think there will be more differences on the way. We're, again, because of the timeline, we really had to just get up and running quickly, and using the CHA database made a lot of sense for that. But there are a lot of things where it doesn't make sense because it's really a very different type of case that we have in ICAN than what you would see in CHA all the time. And the kinds of data that the state wants us to collect are very different than what can be collected through the CHA database. So there are modifications on the way, and probably in the next month or so, you all will hear more about that. But for now, it's only some minor modifications had been made from what was already in there. So this is a web-based, secure case management database. So you access it through your web browser, and it's just communityhealthadvocatesdata.org. And I will set up logins for all of you who don't already have them. So right now, by my count, at least of the people who are on the call currently, I think Courtney and Cassandra, you guys will both need them, obviously, and everyone at Nassau Suffolk, right? So Denise, Vicki, I don't know if Beth, I don't know if you'll need one because I don't think you'll be entering cases, right? And Melissa will need one. Oh, and Ashley, right. Okay, great. Anybody else at Nassau Suffolk who would need a login to the database?
Not right now.
Okay, and you'll let me know. And then at SAIL, I saw that you guys, that a couple of you already have. I think Hannah, you already have a login. Rachel, you already have a login. But Shirley, I didn't see you in the list.
Yeah, this is Hannah. Should we have different logins though for ICAN? Because I know even with CHOP, we have a different login for the small business part of it and for individual consumer assistance just for reporting periods.
No, you can have the same login.
Okay.
The way that we'll distinguish your ICAN work is with a fund code. So every case in the database has to have a single funding code assigned to it. And you'll just have to make sure when you're working on ICAN cases that you pick the ICAN funding code, and when you're working on CHA cases that you'll pick the CHA funding code.
Okay, thanks.
All right, so we'll get logins for everyone, but this is what the site looks like. So you first put in your organization, and then your user ID and your password, and it brings you to this main menu. And so there's really two things you're going to be putting in the database. One of them is cases, and the other is community presentations. So those are the only parts you really have to worry about. So for cases, oh, and an important point, we at CSS, or I at CSS, can see whatever you put in here. But other organizations can't see what other organizations have put in. So, for example, if Courtney at AOP enters a case, then Denise at Nassau Suffolk will not be able to see that case. So there are firewalls between all the different organizations to protect the confidentiality of your client's information. Now, it is shared with CSS, because for quality assurance purposes and reporting purposes, we have to be able to see across all of the different organizations. So as we'll talk about in more detail in a minute, if your client does not consent to disclosing their identity to CSS, then you have to anonymize that record and not put the client's identity in. Then for the challenge then becomes, well, how, from a quality assurance standpoint, how do we identify that case? And how can we go back to you and say, well, we have questions about this case if there's no client identification on the case? So what we're going to ask you to do is put in the case number, or if you have a case number, in your own internal case management system. You can enter that as an identification in our database, and that way it does not divulge the identity of the client to us, but you can still track back to it. If we said, oh, well, we need to see, we're doing QA, we want to see the client file on case number 218, and then you could pull that case file, and we could take a look at it, right? So that's the idea. I think the state had thought that we were all collecting Medicaid numbers on every single case, and I made it clear to them, no, this is not how it works. We're going to respect clients' privacy, And certainly those of us that are law offices have a very, heavy, heavy duty to protect confidentiality. So we would ask if you need to contact a third party, like if you need to submit a complaint, which is a big part of what we do. If you're going to submit a complaint, you have to identify the client in the complaint. And so you have to get consent from the client to do that. And we're trying to come up with streamlined ways of doing that still protect client confidences. And if a client has consented to disclose their identity to CSS, then you can put the client's name in the case, in the database. And indeed, that might make things easier in a lot of cases. So I think each of us has to make a decision as a program. Are we going to routinely ask every client to consent to disclose their identity to CSS, or are we only going to do that in cases where we need to? And I kind of leave that up to you all. The more client-specific information we have in the database, the better use we can make of it. But I don't want to do that in a way that infringes on your own privacy practices.
I would just have one question.
Yeah.
This is Vicki Oskram, National Suffolk Law Services. We have a similar process with our Ryan White funded program. But if we have a client who does not consent, we have a technical assistance agency who does the QA. If they want to see the file, we need some time because we give them a redacted copy of the file, not the actual file.
Right.
So we have to Xerox it. I mean, it's just very primitive. We have to Xerox it, redact the identifying information, and then that's the file that they see. Would that be the process that you use if you're going to overlook a file where the client has not? We do routinely put in, for Ryan White purposes, consents and ask people to sign them so we can disclose their identity to our technical assistance agency that does the quality management, but some clients don't. And that's the way we solve that problem. Would that be how you would be doing it, to come and look at a file?
That we haven't even gotten that far with our QA process yet.
Oh, okay.
I don't have an answer to that, but that sounds reasonable to me. And I mean, I think we're probably going to defer to how community health advocates does QA for a lot of this. But yeah, that's obviously, I think that's a reasonable approach, and we just have to figure out whether that's sort of good enough for the state.
Okay.
All right. So when you're entering a case, assuming that you what we usually do here is the first thing we're doing is looking up the client first. As I'm sure you guys already do in your own intakes, especially if you have to do conflict checks. You have to see whether that person's already in your database. You don't want to make a dupe. This will not work as well for you all because it's not searching clients that other people entered. It's only searching the clients that your organization entered. So it is entirely possible that it's a dupe if they contacted another prong of ICAN. But that's just necessary problem. So you look up the client first. Let's see if I'm in there. And no record was found in the system. So that tells me I can make a new client now. So I click Add New Client. And then, I would be entering the client's name here, but you can also choose this. Client does not want to share information electronically, anonymized client. Right, so if you did that, then the little red asterisks disappear from the name fields. See, anywhere that has a red asterisk means it's mandatory, and you won't be able to save the record without entering that. But if you check this, then the name is no longer mandatory. So up here, this previous system client ID, that's where you can put in your own database's client number or case number for that case so that we can track back to it if you're anonymizing the case. So then, usual just address, county. There are some questions in here which are really, relevant for other programs that we're just sort of stuck with having to answer. And then a lot that are still optional. You put in the zip code, it'll automatically pick the county. And then maybe the client find out about us through notice from a government agency. That's one option. Another one would be if it was from a insurance company notice. And then once you've done that, you can really just skip ahead to add new case. All right, so now we're on the case screen, and we need to put in an open date. And you'll see funding source. That's where you need to select ICAN. And then, filling out some fields about the intake. Is language related to case? Is really, is the fact that the client speaks a language other than English? Is there a communication barrier that's related to their problem? And then literacy would be if they have trouble reading or understanding English, even though they're an English speaker. Then insurance information. This is really important. This is one of the main fields that we want to be able to report on because we want to know which plans we're seeing trends with. There's certain types of problems that really stem from a policy by a single plan and are not an across-the-board issue, and those are particularly amenable to the state, intervening with that one rogue plan. So with MLTC, this is going to look a little bit different than it does perhaps for other types of insurance. The first field here is primary insurance, which is almost always going to be Medicare. The vast majority of ICAN's clients are duals, and so Medicare is usually primary. So most of the time you're either going to be picking original Medicare, Parts A, B, and D, or Medicare Advantage. And of course, every now and then you're going to have someone who's missing one of the parts of Medicare. If it's relevant to the case, you want to enter that accurately. But in a lot of cases, we honestly just assume that they have all three parts, since that's the most common scenario. We don't need to know the effective date unless it's relevant. We don't need to know their Medicare number. And then the primary health plan is going to be none. If they're in original Medicare, there is no health plan. It's just original Medicare. If somebody's in a Medicare Advantage plan, then we'd want the company that they have their Medicare Advantage through. Okay, it doesn't have every single Medicare Advantage plan in that pull down. And again, we're not so much about tracking the Medicare issues, so it's not that important to me that we know the exact Medicare Advantage plan that person is in. We don't need to know anything about their doctor, again, unless it's relevant. Then secondary insurance, for the majority of our clients, that's going to be MLTC. And this is just a convention that we're adopting. I know that people have Medigaps. I know that people have retiree coverage. You could say that Medicaid is their secondary coverage, but we're just, as a convention, using MLTC as the secondary if they're in an MLTC plan. And we know that anybody who's in MLTC has Medicaid. So I don't need both MLTC in one field and Medicaid in another field. MLTC stands in for both of them. and then you'll pick whichever MLTC they're a member of. Tertiary insurance would be that Medigap policy, right? Or it could be, if they have retiree coverage through their former employer, that might be commercial employer non-marketplace. And that's kind of a mouthful, but that's how we would categorize the employer-based coverage. Or if they have it through their union, that's an option as well. And tertiary coverage is, is important, or it could be like VA, for example. Tertiary coverage is important because there are certain issues that arise, definitely in the case of FIDA, but sometimes also with MLTC, due to the presence of that supplemental coverage. So we do want to hear about that. But I don't need to know about, for example, EPIC. EPIC doesn't really impact on someone's MLTC coverage in any way, or their other long-term care coverage, so we can skip that if it's just EPIC. What about someone who just has Medicaid, someone who's not a dual? For them, we will go all the way back up to primary insurance here, and that would be Medicaid. And we would pick their managed care plan. Let's say they're in Fidelis, mainstream Medicaid managed care. Then that's it, we're done, right? Because then they don't have any secondary coverage, they just have Fidelis, mainstream managed care. It would be similar if you had someone who was in one of these fully capitated plans, such as Medicaid Advantage Plus, or PACE, or FIDA. Then you would just have primary insurance, and there wouldn't be any secondary or tertiary. All right, so any questions about the health insurance part? You all still with me?
Yeah.
Okay. We're almost out of the most boring part of the training, I promise. All right, so and when you're ready to close the case, it's going to ask you to confirm what the health insurance is at the case end, because in many cases your work through ICAN will lead to a change in their enrollment. That they came to you, enrolled in one plan, and they left, enrolled in a different plan, and that's something we want to track. So you will have to, it'll copy, when you close the case, it'll copy whatever you entered at case beginning, and then you just have to go in and change it if there were any changes. So chronic health problems, probably. Marital status, we need. And we ask the nosy income questions, even though everybody hates answering them. But do your best. It is possible to say did not report on all of these, almost all of these fields. So while these don't have the red asterisks next to them, a lot of these fields become mandatory when you're ready to close the case. So you will need to have asked those questions, even if you didn't ask it at the point that you're first entering it. You're going to need to answer them when you close the case. And so it's worth asking them up front. But if you have clients who don't want to answer them, that's fine. You can say did not report. A lot of times, especially with these types of cases, you're not dealing with the Medicaid recipient themselves. You're dealing with a family member or friend who might be helping them. That's fine. We still want to know the client, information about the client. I don't care the age or language or health insurance of the adult child or the neighbor. I care about the Medicaid recipient's age, county, health insurance, race, language, etc. So you want to enter the client's information, and then here you can put in the information about the contact person. And that could be you know, advocate, friend, other relative, power of attorney, healthcare proxy, legal guardian. It could be a provider, social worker. So we tried to expand that list there to encompass some more people that we might be communicating with. You know, I think it's really useful to keep track of whether you have documentation. Like, for example, if there was a QA audit and we said, well, we want to go look at the paper file on a certain case, you know, if you put no here, then we know that there isn't any paper file, which, you know, hopefully is not a problem, because we don't need to have paper files on every single case. All right, so if we're done with this, then you can click Go to Need and Service Session. This is the last screen that you have to deal with. And this has a giant laundry list of different needs. So it's very different from how a lot of case management databases work, certainly the legal services ones that I've seen, because it's not trying to categorize their problem or the thing that went wrong. It's categorizing what is it that they need, what are they asking for, and then from there you'll see there's further categorization that ultimately gets you to information about the problem. So, for example, every ICAN case you're going to have need 1.1, needs basic orientation, right? So maybe they know what health insurance is, and they know what managed care is, but they want to know their options. Maybe they need help learning how MLTC works. They need help with the next steps. And everything we do is related to Medicaid redesign. So you could say yes on that. But then things get a little more complicated. And this is one area where we're definitely making some major modifications to the database soon. So let's say there's a caller who has just been approved for Medicaid, or their Medicaid approval is pending, and they need to enroll in MLTC. So that might be this one, needs to choose plan. All right, so you're helping them select a plan and enroll in a plan. You can, you know, answer those questions. Or it might be someone who's already in a plan, and their plan has said they're going to reduce their services for some reason. So then that would be this one, needs help complaining or appealing a service denial. And then you'd select which service is it. And this has a really long list of different covered services under different types of health insurance. So you could say maybe it's home care or personal care. Maybe it's consumer-directed personal assistance. Indicate was the denial pre or post. And was the notice pre or post the denial, and was it in writing or was it just verbal? What was the reason given? Could be not medically necessary. Again, everything is related to MRT. What level? Is this a service authorization level, an internal appeal? Is it a fair hearing? And then what was the outcome? For those of you on Long Island helping people with FIDA, there's another option here. I mean, this is also true for MLTC. There just aren't there aren't very many exemptions left with MLTC. But need help requesting an exemption. If someone is exempt from managed care, then you can select the basis for their exemption here if that's what you're helping them with. So for someone in MLTC who wants to opt out of FIDA, they can choose this. Right. And the rest of these, you know, you'll see apply in some situations, but some of them are clearly more CHA focused, and we're not going to be using them that much. Generally, when it says here, when they use the term coverage, that's talking about insurance, like getting new insurance, getting additional insurance, or just getting insurance in the first place if you were uninsured. Whereas, usually that's not what we'd be doing. The person already has Medicare and Medicaid, and it's not about getting them more insurance. It's about either issues with enrollment in a plan or issues with using the plan, getting things covered, getting prior approval for something, requesting out-of-network coverage, an out-of-network provider, stuff like that. All right, that's the needs. And then the service session, this section is about what did you do? So now we know what the client needed, but what did you do in response to those needs? Well, you spent more than 2 hours on the phone, gave information, orientation, information, advice, obviously almost every case. Maybe we made referrals, and then it asks you who did you make a referral to, investigated or researched, helped understand documents. That could be they got a notice that they didn't understand, and you helped them understand the meaning of the notice. Informal negotiation, maybe you contacted a third party on their behalf. And there's a lot of different third parties we can choose from here. And then, of course, if you're representing them in a formal process, you can indicate which process. If you made a complaint with an administrative agency, if you identified a systemic problem, again, that's a big part of what we do. If you were working on a case and it's something that you think represents a trend, check that box so that we can pull those out. And finally, down here is a place to put your case notes. Since you guys are keeping your case notes in your own external system, I don't know that you need to put all your case notes in here. It also might, if your client doesn't consent to disclosure, it would make it difficult to redact those case notes before putting them in here. But I think you should put something about what the case was rather than just leaving it blank. All right, so we have a question from Courtney on the I think it was the last page on health status. Are we assuming what the answers are, or do we specifically ask those? And then are there any limitations on who we're allowed to work with other than the client themselves? Great questions. So for health status, I've been assuming that anybody who's in a managed long-term care plan or anybody who's receiving home care has chronic health conditions. So I've been saying yes. And I answer no to everything else unless it comes up. So if I'm talking to someone who is a person with disabilities and the plan is failing to make reasonable accommodations to their disabilities, then I would say that yes, disability is related to the case, and then I would categorize the nature of their disability. Is it physical or sensory, or is it cognitive or developmental? And again, like not the most useful categories, but that's sort of what we were stuck with the CHA database. So for the time being, we're just going to keep using those. Mental illness, again, if it doesn't come up, I assume the answer is no. And it's only because you have to answer those to save the case that you're forced to kind of make these assumptions that may be invalid. But what it does is it at least allows me, these are not questions that the state is mandating right now, but what it does is it lets me run a report saying, show me all the cases where somebody's disability was at issue. And that's kind of important to me to know. That is useful for tracking purposes. So if you do help somebody who's, especially if it's a person with disabilities under 65, and that's at all related to the case, then you should choose that you should say yes to that question. Now the second one, are there any limitations about who we're allowed to work with other than the client? And yes, to a certain extent. I mean, the limitation is, well, actually, I'm going to table that for a minute because in the policies and procedures, we get into that. So I'm going to come back to it when we're looking at that page, if that's okay, Courtney. All right, are there any questions so far about the database? And I had to mute some people because there was background noise, so there's a little hand button that you can click if you want to raise your hand, and then I'll know to unmute you so you can talk to me. So a lot of shops will have it set up where there's you might have a couple of different people who are handling ICAN cases, and then there's one poor schlub who has to enter all of the data for them at the end of the month. Hi, Amanda. So that's up to you if you want to do it that way. I think we should all have separate IDs, separate logins, and I know actually, Amanda, we should maybe talk about that, but I think it's good for us to know who did which case instead of the data entry person entering them all under his or her case handler identity. So that way we can really track who did what. But that's fine to have someone other than the actual case handler enter the cases. And indeed, that's something you want to make sure that that person's salary is on the contract, because we recognize that there's a lot of administrative cost to participating with ICAN, and we want to make sure that you're being properly funded for that. I mean, obviously it's money taken away from program work, but that's just something to be prepared for, because we recognize there's a lot of data entry and other administrative stuff involved. So let's enter some case notes. There, those are case notes. And we'll click Save, and there's our case. Okay, Amanda addressed it. Okay, so you'll see here's the case that we just entered. It shows us a little sampling of the information that we put in. It shows us the different needs here, the different services provided. You can click Show Notes, and it just says Case Notes. You can edit what's been entered, and you can, if you're adding anything to the case notes, you go to this go to Need and Service session, and it brings you back to this screen where you have the needs and the services and the notes. So you can always add more notes to that. When you're done working on the case, which probably for most of you doing this at the end of the month is immediately after you've entered it, you click Close Case, and then you get error messages. And we have to, let's see, what did I not do? Service sessions are not completed. Oh, see, because represented informal process, I didn't check one of these. So let's say I did a complaint. And now let's close case. Amount saved, recovered benefits is required. Okay, another error. So this one, this is how much money did you save the client? If you know the answer to that with some precision, then by all means put it in. At this stage, we're not kind of going to great lengths to come up with like quasi-fictional valuations of the service we provide. But if it's something like, the mainstream Medicaid plan denied coverage for a motorized wheelchair, and the consumer went out and bought a motorized wheelchair themselves, and it cost $2,500, and then you got them refunded, then you should definitely put in $2,500 here. But ordinarily, it'll just be zero. All right, let's try this again. All right. So now this is what I was referring to before. It says case beginning health insurance data has been copied to case ending health insurance data. Please verify these before saving the case. Okay. So now if we scroll back up, this is the edit case screen again, and it has insurance information at case beginning. We scroll down, and then here is insurance information at case closing. And there's these new fields that appeared: the closure date, closure reason, and is this a story bank case? So you have to fill those in order to close the case. Make sure that the health insurance is the same. Maybe in this case, this person was in FIDA and they wanted to go back to original Medicare and their MLTC plan. So we'll put that in. So what is this story bank? We want all of our partners to be keeping an eye out for sympathetic clients who might be willing to talk to the press or might be willing to have their stories used in our website or marketing materials for ICAN or lobbying materials to help tell the story about how valuable our services are. And so always be on the lookout for that. And if you have such a case, be sure to indicate yes here under story bank case. And then it's going to ask you right away, media release on file. Okay? So we have a release form that based on what Community Health Advocates does, and we really need everybody to try to get us some of those story bank cases. We try to get the release right away when we're helping the client, rather than waiting until months later when we have an opportunity to use the story, because then it's hard to track people down and get them to sign the release. So really try to get the authorization from people at the time you're helping them. And I find this is a great, obviously it's an awkward conversation to have with someone, but I find this is a great way to deal with situations where you have a very grateful client who wants to give you forbidden presents. If your program is like mine, you're not allowed to accept gifts, although I've always made an exception for edible gifts because you can destroy the evidence. But the client who wants to send you, I don't know, I'm trying to think of a tchotchke I've been threatened with before. You can say, you know what, the gift that would really make a big difference to me is if you would let us use your story in helping, keep funding for this program. And usually people are really happy to help with that. And we try to be very judicious in the information about them that we share, so it's not a complete it's not a complete violation of their privacy. All right, so that's it, and now I'm going to click Save, and all right, it worked. So now the status is closed, open date today, close date today. We're done. All right. So any questions about entering cases in the database? All right, you guys are going to be good at this. So you can see another thing on the main menu that's very useful is this case management bulletin board. This is a way to filter a list of cases. Let's look at all of AOP's cases. Oh, they don't have any. All right, come on, guys. Let's pick up the pace here. You've already been part of ICAN for 2 hours. So you can search by, let's look at my cases, and we could do it by date range. We could do it by just my open cases or my closed cases. And this is a nice way to just keep an eye on your cases, make sure that they're being closed in a timely fashion. Apparently mine are not. And then you can go back and follow up on those. I don't even know what general search does. We can skip that. Reports might be useful for you. I mean, the reports out of this database are not the world's greatest, but I think it is possible for you to generate a report just for your CBO. And then here's the second thing I really wanted to show you, community presentations. So the two things you're going to be entering in this database are your cases and your community presentations. So when we get to community presentations, this is by far the easiest part of the database. Let's say you've just scheduled a presentation that you're going to be doing somewhere in your county. You scroll to the bottom and click Schedule Presentation, and then just fill out these fields. That's it. It's really simple. So pick the date and the time and the name of the presenter. The fact that I've made a login for you in the CHA database does not mean that you are in this pull down. So if one of your staff are doing presentations and they're not in this list, just shoot me an email and I'll add them. And then pick the topic. There are only 3 topics. I'm sorry, there are 4 topics that ICAN should be giving trainings on. Consumer rights and managed care would be, it's what we're using for now for mainstream cases. So if you're presenting, and this is unlikely to happen very often, but if you're presenting to a group of Medicaid onlys, so it's just people, you know that this is only people who just have Medicaid and don't have Medicare, so you're going to be talking to them about mainstream managed care, then you would choose this one. If you're talking about FIDA, you'll choose this one. If you're talking about managed long-term care, you pick this one. And then there's this one, this Intro to ICAN, and this is for mainly for like short presentations where you're just announcing the existence of ICAN and helping get the word out about us and how people can contact you and what kinds of issues you can help with, but not really going into the substance of MLTC or FIDA or managed care. So if it's anything more, in depth than that, then you should pick one of the other topics. There isn't a funding code, a funding source pull down here, so there isn't a way to distinguish. For example, for SAIL, you guys are doing CHA community presentations and also ICAN community presentations. There isn't a way to separate them other than topic. So we're going to assume that if you do something on Intro to ICAN or Managed Long-Term Care, we will assume that that's ICAN. And we're going to count that against your ICAN deliverables, not your CHA deliverables. If you say consumer rights and managed care, that could really go either way. And so you'll have to let us know if you have one, if you give presentations on that. Just send us an email telling us whether that's supposed to be a CHA presentation or an ICAN presentation. I'm sorry we don't have a better way of separating those right now. What language was the presentation given in? Who's the audience? So it could be advocates or consumers or both or caregivers. So advocate also encompasses other professionals like providers, could be social workers, caseworkers, etc. Indicate what organization you were doing the presentation for, where they are, contact person. I guess I need to do this. So let's say I'm doing it for New York City Bar Association, something, 44th Street, York. And I don't remember. Okay. and then save. And now it's in the list. April 1st, 2 p.m., Intro to ICAN, right? So this is a scheduled presentation. It hasn't been held yet, right? So you should enter these as soon as you schedule it so that we can also see what's coming in the future, not just the presentations you've already done. And then once you have the presentation, you go back in here, you click on that date to bring you back to this screen, and up here in the upper right corner is a button that says complete. So that's what you'll do when you've actually done the presentation and you know how many people came. So we just need to know how many participants. That's basically it. So 25 people came. I don't think we're going to be using this thing for tracking educational materials. Maybe in the future we will, but for now, just say none, any notes, and then save. And you're done. That's how you get credit for your community presentations. Now, one question is about sign-in sheets. I am not going to ask you guys to send me your sign-in sheets, but I think it's a good idea to get sign-in sheets and to save them in your file just in case. I will have better guidance for you in the future, but for now I think the best practice is keep your sign-in sheets just so you can substantiate if there's any questions, the numbers that you're putting in of your participants. Okay? If that's going to be a problem for a particular event that you can't get a sign-in sheet, let me know, and we can deal with those on a case-by-case basis. So are there any questions about the community presentation part? All right. This is, maybe I don't have to say this, but this was an issue for my former employer when we became part of ICAN. We know that you guys all have other sources of funding that are maybe funding you to do similar work, and so there's always the question of reporting your ICAN work versus your work to other funders. And what I can tell you is really clear is that the state does not like double counting on state contracts. So if you are, let's say, a high cap organization, you should not be entering a case into ShipTalk and also entering that same case into the ICAN database. You unfortunately have to pick whether a particular case is a high cap matter or is it an ICAN matter. And I know for some of us that meant the specter of a potential loss of high cap numbers because we were probably doing some of our Medicaid work under high cap, and now those are all going to go to the ICAN side. But that's an unfortunate fact of life, and I think the same scenario applies to any other state contracts. Now, if you have private foundation money and maybe they have less stringent reporting requirements, like I can think about when I was at NILAG and we had different foundations that basically we would just give them a report bragging about all the work we did, but it wasn't like, with your money, we did these 20 cases. It was more like, your money paid for us to continue keeping the lights on, and by the way, here's a report of all the work we did. So that's fine. You can tell those funders about, you can include your ICAN cases in the numbers that you report to those funders, just sort of bragging about all of the great work your organization is doing. It's really more about if it's state dollars, that dollar either can only pay for the case once. Does that make sense? All right.
Yeah.
Great. So that's it for database. We're coming down the home stretch here, and by comparison, MLTC is going to seem really interesting tomorrow. I think you guys will just be floored by how much fun MLTC is compared to the database, going through the database and the ICAN policies. So just a couple of top-level things that I wanted to touch on here in this big policy and procedure manual, which is also a work in progress. I mean, it's gone through a bunch of revisions since November, and it will continue to be revised. So some of these things are moving targets. But I want to go over home visits and complaints and confidentiality and communications. So first, let's go to home visits. So this is something that is in our, again, in our proposal to the state insists that we be able to do in-home visits, which is something that most of us were doing anyway just because it was necessary. But if someone requests a home visit, we need to have a procedure in place for processing those requests. I can tell you, as of this stage, here at CSS, I can count on one hand the number of home visits we've done in the first 4 months of ICAN. So it is exceedingly rare. And we've had 3,000 cases, right, and only like 1 or 2 home visits. So it's exceedingly rare that you're going to need to do a home visit. And there are really, I think the main reason for that is that if the main service that we're giving is advice, there's usually no reason why you can't give advice over the phone. And that's great. I'm sure that's how probably a lot of you work. It's a lot more convenient. And when people do want to meet in person, in many cases there's a authorized representative who is willing to come to the office and meet with you. And sometimes the client. I mean, yes, a significant proportion of our clientele are homebound or have difficulty traveling, but some of them have no problem traveling and they're happy to come meet at your office, and there's nothing wrong with that. We want to try to be as efficient as possible. I'm especially mindful of that for you folks in very rural areas where, the time you spend traveling to get to the client's home, you could have done 5 cases, So we try to limit it, but we need to have a policy for when somebody asks for it or when we think it's appropriate, we need to document that in the case file, and it has to go through a certain process. We're going to be modifying the database to include a separate need in the needs section for people who need a home visit, and there will be extra fields in there to track that request, the date that it was requested, the reason for the request, the response to the request. But in the meantime, you really have to just notate it in the case file, all right? And it's all basically common sense. If somebody asks for a home visit, we are generally going to just approve it unless we think there's some other way that the situation can be handled, that a home visit isn't really warranted. And in particular, we want to promote home visits as a reasonable accommodation. So there are a wide variety of reasons that are sometimes too hard to even think about examples of, but a lot of different reasons why somebody might have a hard time taking full advantage of our services if they have to do so over the phone. People who have difficulty communicating, people who have sensory or cognitive issues that make it hard for them to absorb information over the phone, where an in-person meeting is really necessary for them to benefit from the service, then we are going to make every effort to do that. Okay. Here are some examples. Let's say, one reason why you might need a home visit is really just to develop the facts. I'm sure that for those of you who've been representing people on home care appeals, I'm sure this is standard practice. Before you're going to go to a fair hearing, claiming that somebody, was wrongly denied 24-hour care, you should probably go meet the client and see what their needs really are, and take a look at them and see how they do their activities of daily living, and are their claims really substantiated. And in addition to the fact that it probably makes communication easier, and it's nice to actually meet your client in person when you're representing them before a tribunal. So that would be one situation where, of course, it would be appropriate. Another would be where the client just requests it, okay? Then you figure out, you schedule a home visit, even though you maybe haven't even figured, you haven't even determined what the client's issue is yet, right? This is just at the initial point of contact that they say, I can't really get any further with you over the phone. I called you, I want to speak with someone, but I don't want to have this conversation over the phone. It's too hard for me. That's fine. We don't need to know all the details. It may be that you end up doing a home visit where you find out the person's issue isn't even within the scope of ICAN, but that's, I think, just the cost of doing business if we want to be really disability competent for people who have those kinds of issues. Another situation where a home visit would be appropriate is if there's a lot of difficulty communicating. Like maybe the client hasn't requested it, but as you get deeper into the conversation, you realize this is just taking too long. It's really hard for them to understand me, or it's really hard for me to understand them. And then you might say on your own, let's do a home visit, and see if the client is comfortable with that. So once it's been decided that a home visit is appropriate, then the next step is this thing called a risk assessment. I mean, you can tell the state really wanted us to have a real, it's almost like an eligibility determination process. But the risk assessment is just you and your supervisor taking whatever available information you have and just talking about, is this going to be safe for you to go into this client's home, right? Now, I don't know how you would know the answers to some of these questions. I don't know how you know whether a potential client has a history of violence. A lot of these things, hopefully, you can just suss out with your sixth sense, talking to them on the phone. Maybe asking some discrete questions if you're worried about pets. I don't imagine that we're going to be asking everyone who requests a home visit, do you have any loaded weapons in your home? I don't know. I've never done that. I've been doing home visits in New York City for 9 years, and so far so good, knock on linoleum. So once you and your supervisor have decided that there aren't any red flags from the risk assessment, then you can approve the home visit, and you contact them, the client, to confirm. All common sense. Make sure that there's someone for the case handler to be in touch with by cell phone. So if they get to the person's home and they feel like it's not safe, or they're worried about it, or there's some problem, that there's someone that they can call and consult with. And then they should check in with their supervisor immediately after ending the home visit, just so the supervisor knows that everything went okay, and can quickly triage any issues that came up. Now, we do have to have a way to deny someone's request for a home visit. Again, I don't think this is going to happen in the ordinary course of things, but if someone requests a home visit and we don't think it's appropriate, we have to give them a written notice of denial. All right, And I put a template for that letter in the back of the appendix. So that's what we should be using if we have that situation. Now, it hasn't happened yet, so the first time that any of you feel that you need to deny someone's request for a home visit, please just let me know, because I'd love to talk it through with you and make sure that these policies actually make sense. I mean, we developed these in consultation with some of our specialists and with the state, but we've never actually used it yet. All right, are there any questions about the home visit policy?
No.
Oh, all right, great. Okay, complaints. So a big part of what we're going to be doing is making complaints and tracking complaints. I mean, that's kind of the traditional role of an ombuds program, is to be like a public complaint box for a government agency. And we're the public complaint box for managed care plans in the long-term care area. So we need to have a procedure for deciding when something warrants a formal complaint and then how we follow up on that. And this is I think this is really the #1 way that we tell the state, we give the state feedback about the kinds of issues we're seeing in the field, is this complaint policy. So this is worthy of some attention. So first of all, what is a complaint? I'm going to skip ahead to the flow chart, because you got to love a flow chart. So the first step of this process is just, did something happen that wasn't supposed to happen, right? Did something go wrong? Now, you might be thinking, well, something always goes wrong. People don't call us unless things are going wrong. That's true. But I just have to put that in there, because sometimes it's not even clear that something went wrong. Sometimes the client is expressing dissatisfaction about something because the system is unfair. But everybody followed the rules. Nobody broke any rules. Nobody did anything they weren't supposed to do. It's just that very frequently the system is unfair, and people are completely justified in complaining about it. But that's not necessarily something that we want to submit a complaint to DOH about. Let me give you an example. Client calls us and says, I think it's unfair that the state is signing people up for FIDA without their express consent, and unless they opt out. I think that that's sneaky, and they shouldn't be allowed to do that. Well, it's the law of the land. Both the state and the federal government have no problem with this. So it's a pointless complaint to make in some ways. Now, maybe you make a complaint anyway. Maybe the client makes a complaint anyway. I think it's important for the state to hear about it. But far from being a violation of some rule, it's the rule. That's how it works. You could say maybe you write your congressman, and give them a way to feel some vindication that way. But it might not be a complaint through ICAN. So the next step is, and this is maybe a different way of asking the first question, but did it involve a potential violation of a rule? So the example I give here is, let's say someone's calling you because their managed long-term care plan won't increase their hours. They asked for an increase from 4 hours a day to 8 hours a day, and the plan said no. All right. Well, the consumer has appeal rights. So you can help them do an appeal and challenge that factual assertion about the medical necessity of 8 hours a day. But it's not necessarily appropriate for a complaint, because again, the plan didn't violate any rules. The plans are completely within their rights to make a determination of medical necessity that is different than what the client thinks. And they're following the rules. As long as they've given proper notice and given the, notified the member of their appeal rights and they followed the procedures, that might not be a complaint. That might just be, well, okay, we have recourse. We have the chance to do an appeal, and we'll do that. If, on the other hand, the plan didn't give written notice or gave defective written notice or didn't give the person aid continuing when they reduced their services or things like that, that would be germane for a complaint because it's a violation of a rule in law, regulation, guidance, or contract. So any questions about that distinction? All right, great. So if you've answered yes to the first two questions, you now know that you may properly do a complaint in this case. And the next problem is figuring out who do you complain to, which is a challenge in and of itself. So this last section of the chart is really just to figure out who was the bad guy, and therefore which entities do you complain to? So if the responsible entity seems to have been, let's say, an MLTC plan, like if it was the no notice scenario, that somebody's services were discontinued without notice, that would be the plan was the one who did something wrong. So you would want to send an email to the TAC. This is the, there's a whole sort of complaints and case assistance office within the Department of Health, within the long-term care division called TAC, and they have their own toll-free number and their own email address. So you can use this email address to submit complaints about a specific plan, and you should also CC that plan's liaison. Every plan has a liaison designated for ICAN, so that we have someone we can reach out to at every single plan that it's part of their job to respond to inquiries from ICAN. So it's a huge help. I mean, this was always kind of my first choice, even before having state-designated liaisons. You just try to make contacts at these places and use those contacts when you have trouble on cases. And I found that to be the most effective way of resolving problems. But now it's their job. They're not just doing me a favor. And so that's very, very powerful. And in fact, one part of the complaint policy that's elsewhere in this handbook, it's not on this chart, always think about the timing of a complaint. If there's two kinds of complaints. There's the complaint where you haven't fixed the client's issue yet, like they still need relief, and then there's the kind of complaint where you have fixed their issue, and the complaint is just to report the bad thing that happened, right? And so those are very different. If you haven't gotten relief for the client yet, and there's still an open issue that needs to be resolved for this individual client, it's not just reporting the existence of a problematic behavior. In that situation, I would say don't file the complaint right away unless it's something really dire, because you may lose some leverage that you have with that contact at the plan. I think your first recourse should be reach out to the person at the plan. Reach out to the plan liaison and tell them, hey, I have this client whose services were just discontinued without notice yesterday. You know you guys aren't allowed to do that. Can you please reinstate their services? And obviously we're going to appeal this. Well, in some cases, that contact to the liaison can solve the whole case. You can be done with that, by contacting that person. And hopefully, the fact that you're calling from ICAN motivates them further to fix these things. And it may be that, you have either stated or unstated leverage with them saying, look, I can report this to the state, but I wanted to give you a chance to fix it first. And maybe you report it to the state anyway, but then you can at least say, when you report it to the state, give them credit. Say, I reached out first to the plan liaison, and to their credit, they fixed it within 1 business day. But I still just was alarmed by the fact that it happened in the first place. So that way, you have a little bit of leverage. You give the plan a fair chance to try to fix things, but you still have the ability to get it on the state's radar screen. Now, there are some cases where you just need intervention right away, and the complaint may be both seeking relief and also reporting the problem. And so you can just CC the plan liaison. And if they get back to you, that's great, but you're not waiting for them to fix it before you tell on them to the state because it's something so dire. For all complaints, please CC ICAN complaints at cssny.org. That's a mailbox that I set up just for us, just for people within ICAN. It's not for the public to use, but it's for people within ICAN to CC complaints to, so that I can track them and make sure that that I know whether issues have been resolved or not. So there's a similar process for if it's a mainstream plan. It's a different email address for mainstream. If it's a FIDA plan, this is again just for Long Island. For FIDA plans, they go into something called the complaint tracking module, which is a federal database that is used by CMS to track Medicare issues like Medicare Advantage or Part D issues. That's also used for these FIDA plans. So you guys will need to be trained on the complaint tracking module, and I'll have to get you logins for that. If you have issues with FIDA plans before that gets set up, just let me know, and I can put something in the complaint tracking module for you.
Okay.
The next entity here is New York Medicaid Choice. So as most of you probably know, they are the enrollment broker for all Medicaid managed care in New York State, including MLTC and FIDA. So if New York Medicaid Choice screws something up, then we have contacts there, and here we have one, Anna Rodriguez, and it's the same issue with plans. Reach out to them first if you have time, and see if they're willing to fix it for you before you go ballistic, because in many cases they're willing to. The CFEEC is a relatively new program that New York Medicaid Choice is operating in a large part of the state now, and gradually rolling out to more of the state. It's the Conflict-Free Enrollment and Evaluation Center, and that is for managed long-term care for people who are trying to enroll in managed long-term care. They have to be assessed by this conflict-free entity before they can enroll in a plan. The conflict-free entity just says whether they are or are not eligible to enroll. They don't determine the services, they don't determine the hours. They just give a green light or red light on that person's eligibility for MLTC. Basically, are they functionally impaired enough to qualify for MLTC enrollment? So if there are problems with that process, there's a separate email box that I think those complaints should go to. And lastly, you're going to have cases where there's a grievance against a provider, maybe a home care agency or a nursing home, whatever. So I provided here some other avenues of complaint, and otherwise those can be handled the same way as the other complaints. So there are links here for either forms or online tools or email addresses that can be used to complain about these different entities. And there's a textual version of that whole process here, but I thought it was just sort of easier to see visually. So when you submit the complaint, at least in terms of the TAC, and I think this is also true for the mainstream complaint box, it doesn't need to be really long. You know, draft a pretty concise statement of the relevant facts and what rule you think was violated, and if you're requesting any relief or if the issue's already been resolved. Really just a couple of paragraphs. You gotta include the Medicaid number. They don't want to get complaints from us without the Medicaid number, because in many cases, well, the state claims that in many cases they're seeing duplicate complaints where somehow someone called their TAC complaint number and then they also lodge a complaint through ICAN. And so the only way that they can merge those and know that they're one case instead of two cases is if we give the Medicaid number. So a precondition of lodging a complaint is getting the client's consent to disclose their identity to the Department of Health or whichever other entities you're going to be complaining to, including sharing it with ICAN. Another consequence of this, we'll talk more about this in a sec, ICAN, and therefore all of you, are covered entities under HIPAA, unfortunately. So it means that any time that you're transmitting protected health information, it needs to be encrypted. So when you send that complaint to these different email addresses, you have to put the complaint in, let's say, Word, and then password protect the Word document, and send the password separately to the entities you're complaining to. All right. And in terms of the tone, you know, it's a persuasive document, but it's not like it's not quite the same that you're writing a brief, because we're not acting as, on these complaints, it's not so much like we're an attorney arguing that the judge should provide certain relief, like arguing that, you know, how the law applies to a certain set of facts and therefore this relief is required. It's more like, because we're not the regulator, you know, we're not adjudicating. You know, when you write a brief, you're sort of telling the judge how to adjudicate something. We have to take a slightly softer tone with this. It's more, these are the facts, this is what we think went wrong. You know, we didn't invest, you know, we're an investigative body. We can say we investigated it and this is what we found out. And, you know, we think that it would be appropriate to do X. But just, we always have to be mindful not to seem to the state that we're usurping their regulatory role. It's different, you know, we're not trying to pull any punches, really. It's just about tone. And we already talked about in the database how there's a place, obviously there's a place to track that you've made a complaint, and there's a place to track that it's a systemic problem. They're not necessarily one and the same. I mean, I can imagine lodging complaints that don't represent systemic issues, but in case it is something that seems to be a standard policy or practice affecting multiple clients, then you should choose identified systemic problem. All right, any questions about complaints?
No.
No? All right, coming down the home stretch. We might finish early. So the last part is confidentiality, and so we have, as I said, we're a business associate of a covered entity, and all of our subcontractors are therefore also business associates. So what's good for the goose is good for the gander, unfortunately, and whatever precautions the state has to take as the Medicaid program, whatever precautions they have to take under HIPAA, we have to take too. So it means that the privacy rule and the security rule apply to us. And we're trying to find the right balance between protecting ICAN clients' confidentiality while at the same time not making the process so onerous that it impairs our ability to get the job done. So this will be going back to a question that I think, I can't remember who it was who asked earlier. Who are we allowed to talk to? Well, first of all, communication between the caller and ICAN. We don't need any kind of release or consent to talk to someone. Okay? Anybody can call us, and we will be happy to talk to them. We don't necessarily need the actual Medicaid recipient's personal information. I'm sorry, let me rephrase that. While we may need the actual Medicaid recipient's personal information, obviously we need to know about their health insurance and certain other facts about them just to give advice. We don't necessarily need an authorization from them in order to talk to a family member or friend. So if the adult child of an older adult in MLTC is calling, you don't need to, I don't want people saying, oh, well, we can't really talk to you until we get a power of attorney. You know, I think that's imposing an unnecessary obstacle. Let's assume that the person who called has been authorized by the Medicaid recipient to talk to you. And they're going to give you information about that person. We don't know whether they were authorized to do it or not, but that's their problem. We're not violating anybody's confidentiality because we don't have any information. We're not looking, at least not yet, we're not looking someone's information up in the Medicaid system and then sharing it with an unauthorized purported representative, right? So it's really a one-way street, and we just take the information they give us at face value. But whatever the information we get, we cannot divulge it to anyone outside the sphere of ICAN, and actually even within the sphere of ICAN. You can't divulge it outside of your organization without their consent. So how do we deal with communication between ICAN and third parties? Like if you're calling a plan to try to solve a problem, if you're calling the enrollment broker, if you're emailing a complaint to the Department of Health, if you're even talking to CSS about a case or to one of the specialists. Well, the majority of these situations, based on the research we've done so far, we believe that oral consent should be sufficient. Just oral consent notated in the record. Now, we're going to have a 3-day-long HIPAA extravaganza in late April with our HIPAA consultant, and just, you know, maybe it makes you feel better about being on this really boring 3-hour-long conference call with me. It could actually get worse. It could be 3 days with a HIPAA consultant, that person will hopefully give us some more detailed guidance on what we can or should do. But for now, the policy is that if what you've got to do is submit a complaint or talk to CSS or talk to the plan, that oral consent is sufficient. Now, in many cases, let's say you need to talk to the plan or you need to talk to the enrollment broker, just do a 3-way call. That's the easiest, assuming that your phone system permits it. Because then the client themselves can give consent directly to the third party. All right? Because if you're trying to talk to a plan and you call the plan up and you say, well, trust me, the client gave me oral consent, I have it in my case notes, they're not going to accept that, right? I mean, if they do, God bless you, get as far as you can, but probably they're not going to accept that. So in those cases, you really want to have the client on the three-way call. And we've been doing a lot of that with the enrollment broker, and it's been working fine. It has not represented a real obstacle to efficiency. But if you're, let's say, submitting a complaint, that's where I think the oral consent is most appropriate, because the complaint, it makes most sense to do those in writing and therefore by email. So this just goes through sort of a little script for obtaining oral consent. Eventually, there'll be a specific place in the database to indicate consent that's been obtained and for what purposes. But for now, just put it in the case notes. And then there are going to be some situations where you need written consent. So, you know, if you're at least down in New York City, if we want to talk to someone in HRA, our Department of Social Services, about a case, they're not going to talk to us without their own form. They have their own HIPAA form. So, all right, we got to get that signed and fax it over. You know, if you need to get medical records from a provider, if you're doing a formal appeal, in situations like that, you really should have written HIPAA authorization. Now, let's say the client calls you, you've been talking to the client, and then you get a call from somebody saying that they're the son of the client. You can't tell the son anything. You can't even tell the son that the father or mother called us, because you don't know whether the client consents to disclosure to that purported family member. So if the son says, you know, hey, listen, my dad spoke to you earlier today, I just wanted to follow up because he sounded really confused, you can say, well, he would need to give, you know, if he called us, he would need to give me permission to talk to you, or else I can't talk to you, right? So then the son can get dad to call back and give you permission to talk to the son. And oral consent is fine for that purpose. And it just talks about some of the different releases that that might be used. All right, and then finally, all right, so any questions about confidentiality?
No.
All right, communication guidelines. So we have what I hope is a powerful tool to influence state policy through the Ombudsman program. We've already had a lot of conversations with the state, especially around the rollout of FIDA, where I feel like we have influenced state policy in a way that wouldn't have been possible if we didn't have this ongoing open channel of communication with the state. I mean, every week I'm talking to them. I'm talking to the people who are running the long-term care division for the whole state, and we're bringing these issues to their attention. We're not the only ones doing it. I mean, there's the Duals Coalition, there's Medicaid Matters, and you know, a lot of other organizations doing great work advocating for policy change with the state. But this is just an extra tool in the arsenal of advocates to help influence policy. And so I hope that people will feel that this is an increase in our ability to be good advocates. But it comes at a cost. And the cost is we just have to be a little bit more circumspect in terms of how we communicate outside of ICAN. So the upshot of this is that we should not share any information that we obtain through our work with ICAN with any third parties without running it by me first. And in some cases, I will have to run it by the state first. So what does that mean? It means, let's say, through your work in ICAN, you find out that let's say, well, this is actually a real-world example. You find out that the state has a policy of not allowing people to opt out of FIDA in writing, and that this appears to violate CMS guidance. So what I'm asking you to do is don't write a letter to CMS, or don't talk to a reporter about this issue until we've had a chance to talk about it. And the reason for that is to give the state a chance to fix it. Now, the state acknowledges that if they don't fix it to our satisfaction within a certain period of time, we're within our rights to report out. And indeed, I think it's our obligation as the ombudsman to report out and to say, you know, this is happening, it's causing harm to consumers, and we're not happy with the state's response to it. And that's fair. The state just doesn't want to hear about things for the first time by reading an article in the newspaper or hearing about it from Medicaid Matters, saying like, oh, Medicaid Matters told us that ICAN is getting, you know, that ICAN is getting lots of calls where, you know, this plan is reducing people's home care services arbitrarily, right? We don't want the state finding out about it that way. We want them to find out about it from us. And so the plan is, when we identify these kinds of issues, and you'll learn about the different ways that we identify them on the monthly case review. We identify them through the listserv, which I'll talk about in a sec. We'll identify them through looking in the database. But assuming that we identify an issue, at that moment we're going to sit down and say, okay, what is resolution going to look like, and how long are we going to wait? And that way we can go to the state and say, this is what we're asking you to do, and this is when we want to see it happen by. And if it doesn't happen by that time, then we can report out. You know, so hopefully this doesn't mean that I don't want us, again, like the last thing I want is for us to feel like we have one hand tied behind our back while we're trying to advocate. But it's just giving the state a fair chance to try to fix things. In many cases they have. But they're really, really antsy about the public perception of their programs, especially FIDA, but you know, the same thing goes for the other programs as well. And so we just have to be mindful of that, really for our own self-protection. We just don't want anybody to be in a position where they're having to, you know, explain themselves for something that gets interpreted the wrong way. It's not to say we don't want you talking to the press. We want everybody talking to the press because we want to get the word out about ICAN. We want to do good marketing, but just let me know. Just give me a heads up before you talk to someone, and so we can just figure out, you know, what your talking points are going to be. We've already had someone who, you know, was totally misquoted, and it made it look like they were bad-mouthing the program when they really weren't. And that's just a headache that we don't need. It doesn't mean that you can't participate in advocacy coalitions. I mean, I participate in the Duals Coalition and Medicaid Matters, and you know, I think it's completely appropriate for us as the Ombuds program to be to collaborate with other groups, but we just have to kind of remember that you've got your ICAN hat on, and be careful about what you say. Just if there are things that aren't public yet, we can't share those with our colleagues in the coalitions, even if they're even if they're our coworkers. Just to make sure, again, that we don't lose control of our information, which is one of our greatest assets. So there is a listserv. It's a Google group which I'm going to have everybody sign. I'm going to sign everybody up for. So the email addresses that I have already for you guys, I will automatically sign those up for the Google group. It's I don't remember what the address is, but it's an email address that you can then use to just email everybody in ICAN, everyone here at CSS and the specialists and the CBOs. It could be questions about issues that are coming up in your work. It could be questions about ICAN. It could be sharing a resource that you found to be helpful. We have a good discussion going on that group. I think it's a really, really helpful resource for all of us. It is within the sphere of ICAN, so it's not public. The state is not on that. The plans are not on that. It's just for us internally, and it's a great way also to talk about possible systemic issues. When you're spotting something problematic, you can share it with the whole group, and then maybe you get a bunch of people who give you me toos and say, yeah, I saw that same issue, and that lets me know that this is something we need to escalate to the state. All right, so that is it. Are there any final questions? Until tomorrow.
See you tomorrow.
We'll see you
All
tomorrow.
right. You guys made it. You guys made it. Thank you so much.
Take care.
All right. Have a good night.